Welcome to PT Micro Lessons, fast lessons with big impact. In this lesson, we're going to look at mechanical traction and how it is used in clinical practice. Okay, let's start with an overview of who benefits from mechanical traction. Here you can see the list of common textbook indications. However, research suggests it should primarily be used for centralization in patients with radiculopathy or radicular symptoms. There are also individuals who may benefit from cervical traction if they have age-related degenerative changes, such as osteoarthritis or degenerative joint disease. Ultimately, traction should be guided by patient response, not just diagnosis. Overall, we will discuss cervical and lumbar traction in this micro lesson. Let's start with cervical traction and its indications. Fortunately, there are two commonly referenced clinical prediction rules that help guide the use of cervical traction. Wehner's cluster is used to identify cervical radiculopathy. This helps confirm that the patient's symptoms are nerve root related, which supports the use of traction to reduce symptoms and promote centralization. Rainey's rule builds on this by identifying patients more likely to respond to traction. Many of the criteria overlap with radiculopathy, reinforcing that traction is most useful in this population. Overall, these rules are similar and help guide you toward patients who will benefit most from cervical traction. One key difference is that Rainey's rule includes age 55 and older. This likely reflects a subgroup within this cluster with degenerative changes, such as osteoarthritis or spondylosis, who may respond well to traction. This ties back to what we discussed on the previous slide about cervical traction for individuals with age-related degenerative conditions. Okay, let's look at the setup for cervical traction. The patient is positioned in supine, often in a hook-lying position for comfort. The angle of pull varies by target region. For upper cervical segments, a neutral angle is used. As you move lower in the cervical spine, increasing flexion is used. Traction in the range of 20 to 30 degrees is most common, especially for lower cervical segments. This angle of pull is also commonly used for patients with degenerative changes, such as osteoarthritis. Now let's walk through the key parameters for cervical traction using the FIT framework. Starting with frequency. Cervical traction is commonly applied 2 to 3 times per week for about 3 to 4 weeks. For some patients, especially those using a home unit, it may be used more frequently, even daily. Next is intensity. Begin with a low load, typically around 8 to 10 pounds. Reassess symptoms within the first few minutes. If the patient reports improvement, the load can be increased during the same session by about 3 to 5 pounds. Across sessions, continue to reassess and gradually progress. Over time, traction may be increased up to approximately 30 pounds, depending on tolerance and response. For time, start with shorter durations, around 5 minutes. As tolerated, this can be progressed to about 10 to 15 minutes to achieve an adequate treatment dose. Finally, type. Intermittent traction is most commonly used for patients with radicular symptoms, typically with a 60-second hold and a 20-second rest cycle. Static traction may be used in patients with higher irritability or guarding. Overall, these parameters should always be adjusted based on patient response, with the goal of reducing symptoms and promoting centralization. Let's clarify a key idea about intermittent traction. The off time does not mean the force goes to zero. Instead, the load is reduced from the peak force during the on phase, while some traction is still maintained. This helps maintain decompression while giving the patient a brief rest. Clinically, we also want to avoid dropping the force too low during the off phase. If we do, symptoms may return, especially in individuals with radicular pain. So think of the off time as reduced load, not back to zero or no load. It is there to increase tolerance while maintaining the treatment effect. Let's take a closer look at the lumbar traction subgroup described by Fritz and colleagues. These patients present with signs of nerve root involvement, such as leg symptoms distal to the knee, positive straight leg raise testing, and peripheralization with extension. At first glance, this may look like a flexion-based pattern. However, that is not the case. The study specifically excluded patients who are more likely to have spinal stenosis, in which flexion is typically beneficial. Instead, these patients likely had a posterior lateral disc herniation and would typically be considered extension-based. However, in this case, they did not respond to extension as expected. In other words, they failed the intervention that should have worked. This is where traction becomes useful. Traction can reduce compressive forces and help improve symptoms, allowing the patient to move back toward an extension directional preference. In fact, in the study, traction was applied in the prone position, and patients were still guided to perform extension-based movements. So rather than thinking of this as a flexion bias, it is better understood as an extension-intolerant nerve root compression pattern. Now, let's walk through lumbar traction parameters using the FIT framework. Lumbar traction is most commonly performed in supine, often in a hook-lying position for comfort or flexion-based stenosis cases. However, prone positioning is common for individuals with nerve root involvement who are better suited for an extension-based approach. In terms of intensity, Begin with a lower force, typically around 25 to 50 pounds, and progress as tolerated toward approximately 40 to 60% of body weight, always guided by symptom response. For time, start with shorter durations of about 5 minutes and increase as tolerated to roughly 10 to 20 minutes to achieve an adequate treatment dose. Regarding type, intermittent traction is most commonly used for individuals with radicular symptoms, often with a 60-second hold and 20-second rest cycle, whereas static traction may be more appropriate for individuals with higher irritability or guarding. Finally, frequency is typically 2 to 3 times per week for about 4 to 6 weeks. Overall, these parameters should be adjusted based on patient response, with the goal of reducing symptoms and improving function. We will wrap up with precautions, contraindications, and adverse effects for mechanical traction, and think about how these categories guide clinical decision-making. Starting with precautions, these are situations where traction may still be used, but with increased caution and closer monitoring. For both cervical and lumbar traction, this includes things like hypermobility, swelling, poor tolerance or anxiety with traction, cardiopulmonary insufficiency, and decreased bone density, such as osteoporosis. For the cervical spine specifically, we also want to screen for signs of vascular compromise and consider TMJ sensitivity, especially given the halter. Overall, precautions don't necessarily rule traction out, but they should make you more conservative with your parameters and more attentive to patient response. Next are contraindications, situations in which traction should not be performed. For both regions, this includes acute sprain or strain, active inflammation or infection, joint instability, tumors, rheumatoid arthritis, uncontrolled hypertension, and fracture or high fracture risk. For the cervical spine, any signs or symptoms of vascular compromise are a clear contraindication. For the lumbar spine, we should consider conditions such as pregnancy, abdominal or inguinal hernia, and significant circulatory or respiratory problems. In these cases, the potential risk outweighs the benefit, so traction is not appropriate. Finally, let's look at adverse effects, which are responses that may occur during or after treatment, and signal that something needs to be modified or stopped. For both cervical and lumbar traction, this includes peripheralization of symptoms, worsening distal pain, increased neurologic symptoms, or a rebound effect where symptoms worsen after treatment, as well as nausea. With cervical traction specifically, you may also see dizziness, lightheadedness, visual changes, or TMJ discomfort related to the halter. These are important because they guide your in-session decisions. The key takeaway is to continuously monitor patient response. If symptoms peripheralize or worsen, traction should be modified or stopped.
That's it for this PT Micro Lesson. Like and follow at PT Micro Lessons for more fast lessons with big impact on physical therapy topics.